For a whole brain simulation, you want, just as with all simulations, to get your patient onto the table properly. You want to have them lay down straight, as we discussed last week. You want to make sure that you have them straight with a laser, no matter what end of the body you're treating, whether you're treating their knee or their head. The entire body, as you can see, needs to be straight with the laser. The laser needs to run right between their crotch, right up their belly button, from their xiphoid, SSN, chin, nose, glabella, the whole 9 yards. Straight every time. Every simulation. Every time. For the whole brain, you want to have them ballparked such that you have the laser running right through their head from chin to glabella. You don't want them crooked like that. Okay, you don't want the side of the chin in the middle of the forehead. You want to have the laser running such that you have them bisected in half, left to right. You're going to make your mask. We've already had a video about mask making. Here's the mask that we made on this head. So we're going to pretend like, boom, we just made a mask. While the mask is drying, you're going to do the rest of your simulation. So we have the mask in place. You have them ballparked. Now, standard field size that you always start with for a whole brain is 22 by 17. 22 by 17 fits almost every noggin in America, and most in the rest of the world too. You will have some adjustments to go with on after that, but 22 by 17 is your standard field size. You could even be tested about that. So we've got them bisected left, right. The next thing I'm going to do is run them straight in until the laser is right about the top of the ear. Ballparking, let me back up just a little bit. Ballparking for a whole brain. Can you see laser at all from that side? You cannot.
It's too dark. I mean,
There,
too bright.
if you have your patient ballparked correctly and you don't have an ear to look at on this patient,
Okay.
your ballpark is going to look something like this. In, out, you're right about the top of the ear, or 3 finger widths superior to the EAM. So you can find the EAM and go 3 finger widths superior. I can't even see the laser, but I think that's probably about it. That usually falls pretty much the top of the ear. Depending on the size of the patient's ear, that's about where you want to be. So in about there, and then up, down, right about even with the EAM is another ballpark. We're going to pretend that's the middle of her ear. Right about there. And if you look at the laser, can you see the laser?
Mm-hmm.
Okay. You can see that that is, if you can see my finger, there's the back of her skull where my finger is. Here's the anterior portion of her skull. That laser is almost right halfway between the posterior flash and the anterior flash. As we all know, that might come into play on a whole brain. So we have the patient ballparked. I've got the field size set to 22 by 17. I'm going to rotate on over to the lateral. And then we're just going to look and see what this looks like on the patient. And we'll kind of look and see what the flash looks like. The flash itself looks fabulous. We've got anterior flash. We've got superior flash. And you don't necessarily see it, but we have posterior flash as well. You can see the field size is all the way down here. I don't know if you can see it, but I can actually see some flash coming around through the clear headrest right there. That's not necessarily something you're always going to see. You may end up only being able to see it on the radiograph. But just looking at the flash portion of this, I can see that we've got the patient ballparked pretty well. Now, since she's got kind of a small head, I need to be on this side to look. Actually, I'm going to go to the top of the table. So we can see that we've got a little bit of flash. You can see the bottom of the field is right here. What you can do if you don't have a collimator rotation, as we may have discussed, some physicians will have no collimator rotation, and then they will do something akin to this with blocking. And this is what it will end up looking like on the patient. Or you may actually have a collimator angle to create that inferior border. But the inferior border is always going to be a line running from the outer canthus to the mastoid tip, or EAM, or tragal notch. Just like we talked about last semester. All of the other flat borders are 1 to 2 centimeters of flash. Anterior flash, superior flash, posterior flash. If, indeed, we want to do a collimator rotation, this is what it will end up looking like. And I'm going to be behind the camera for this. I'm going to turn the collimator thusly. You're going to run the patient out and down. You have to do a little bit of stair stepping. And since I'm dyslexic, I moved the collimator the wrong way. So, as we wait, we're going to run the collimator the opposite direction. I apologize. So you want that inferior border running in a line from the outer canthus to the mastoid tip or EAM. And then, since I ran the patient down too far, we're going to do this. That's approximately it. So you're going to end up with the inferior border running from the outer canthus to the EAM or mastoid tip, while continuing to have flash anteriorly, superiorly, and posteriorly. That's where you need to have your initial field border set. So once you have this done, what you need to do is go ahead and you've got everything set. You've got it ballparked such that you think it's about equal distant from both laterals, because your whole brain is going to be a mid-plane setup. This is ballparked. You're going to run out of the room. You're going to fluoro. This is the fluoro II, the image intensifier. It can get in the way sometimes, so you have to be careful of it at all times when you're doing a regular simulation. So you run out, you're going to fluoro. When you fluoro, you're going to double check that radiographically your inferior border runs from outer canthus to the midline, or to EAM. Once you've got that set and you think it's good, you call the doctor. The doctor's going to come in. He's going to look at it. He'll step on the floor and move it 3 millimeters and say, okay, now it's good. Once he's got everything set and he's okayed it, you're going to run in the room, and the first thing you're going to do is you're going to have, for a mask, a piece of tape ready to go. She's got such a small head, we have an issue. There's going to be the CR. You're usually not going to see the CR that far up on the patient, but for argument's sake, that's what we're going to do. So you're going to actually mark the CR on the patient. The next thing you want to do is rotate the gantry up so that you can see the opposite laser. We're actually going to end up rotating all the way around eventually, but we want to rotate up. Image intensifier's out of the way. Trust me, you can see the opposite laser over here. You're going to actually mark that, just like you did, and then rotate back. Once you rotate back, you've got 2 marks on the patient now. If everything goes pear-shaped and you have to get the patient down, you can at least reproduce this from this point going forward. The next thing you want to do is have some calipers that I don't have in the room. So you're going to have calipers. You're going to take a separation between the CRs, see what the separation is. We've discussed how to figure out what an SSD should be mid-plane, correct? Let's say the separation is 10 centimeters. You're going to take 10, divide by 2, minus 100. It's going to give you 95. So you should have 95 SSD on both sides. Once you've determined this, you're going to double check that SSD and see if your ballpark was good. If not, fix it. Once you've fixed that, make yourself another mark on the anterior so that you now know the left-right. So we know exactly where it's going to be mid-plane. You've got those marks on the patient. Next thing you're going to do is take film. Put your cassette in if you have a cassette. If it's an EPI, don't worry about it. If you're taking a regular film, you want to make sure that the entire field is contained on your film. Don't have flash out here somewhere. Center your II, set your TFD, and put your field marker on your patient. This is a left lateral. You're going to put like a left lat where you can see it on the x-ray. Okay, this is the 3 things you're going to do for every single film that you take. You're going to do 3 things. We've already discussed this, but we're going to go at it every week. Center your intensifier, set your TFD, put a field marker on every time. So now that we've done that, we're going to go take our film. Run out of the room, buzz, take the film, come back in, run this film. Do not move your patient or your gantry. Go run the film and have it approved by the physician. Physicians sometimes will change their mind from the time they fluoro until they see the x-ray. X-ray is a better picture of what you're looking at anyway most of the time than a fluoro, so they need to see that whole picture. Once he's approved that film, come back in, rotate over, and take your other lateral. Now, in this particular case, we have a collimator angle. When you rotate to the opposite lateral, mirror your collimator. Anytime you have a collimator angle or a table angle, when you go from one lateral to the next, you have to mirror the collimator or mirror the table. One or the other, sometimes both. So, however many degrees off you are from this side, you're going to go that many degrees off for the opposite lateral. So you can do that calculation in your own head, but just know that you mirror your collimator, and technically you're mirroring your gantry as well. You're going to have to go from 90 to 270. Take the other film, get it approved, your patient's marked up, take your pictures. When you take photographs, I think we've already covered this too, but I'm going to cover it right now. You want 3 pictures of your patient. You want a lateral, you want an anterior, and when you want a full body picture. When you take the full body picture, if the patient's covered up in a blanket, uncover their body enough to where you can see the setup. If you take a picture of a patient under a blanket, that's a morgue picture. That is not a setup picture. You want to be able to see, was there a table pad? Where were their hands? Where were their knees? Did they have a knee rest? Did they have back lock? Did they have their arms in a certain position? Where was their head? You want to be able to see head to toe, straight laterally, everything going on. If it's covered up, uncover it. Make sure that you have a good view of all things. Now, when you take the anterior of any photograph, when you're looking at your patient, you're here looking at them as if you were face to face, correct? You don't look at them sideways all the time. When you're setting up a patient, you're looking at them this way. Take your photograph in such a way that you see them with the head portion at the top of the picture, the foot portion at the bottom of the picture, not side to side. Because when you bring that up on a screen, you're going to have a sideways picture, and you're going to want to go like this so that you can see the orientation that you're needing to see. Lateral pictures, straight lateral, anterior goes to the top of the picture, posterior goes to the bottom of the picture. And the AP picture, the superior portion goes to the top of the picture, the inferior portion goes to the bottom of the picture. This is indeed a pet peeve of mine, that's why I'm preaching about it. But it makes more sense, and if you want to be able to have it oriented the same way every time, be able to see it quickly and easily, do it the same way every time. Oriented how you would normally look at the patient. So for the whole brain, take a lateral picture here, turn, anterior picture here, and back away, uncover them, take a picture of the entire body. Now that you've got that done, you're going to get the mask off, you're going to educate the patient on what's to come next, and they're gone. You're finished with your sim. Thank you for your time.